Hello, my name is Marcos Arrieta Garzón, and I am a nursing student at the Catholic University Santiago de Guayaquil, and I have come to speak about the necrotizing soft tissue infection. Definition: necrotizing soft tissue infection tends to occur in immunocompromised patients with degenerative diseases. However, this infection also occurs in people with no pathological history due to a set of aerobic and anaerobic microorganisms which enter the body through a minor wound or scrape. The bacteria begin to multiply and release harmful substances, toxins that destroy tissues and affect blood flow in the area of location. This infection in turn spreads rapidly, affecting the subcutaneous tissues in addition and spread into the tissues deeper. Streak also produce chemicals that block the body's ability to attack these organisms as the tissues dies.
Hello, this is Jacob Avila of 5 Minutes Sono, and today we are going to talk about necrotizing soft tissue infections, or as they're also known as necrotizing fasciitis. Your probe of choice for this examination is going to be the linear transducer. This has the highest frequency and will give you the highest resolution image. Now, there are a few ultrasound findings that you can look for to try and diagnose that NSTI, and that includes thickening of the tissue, deep fluid collections, fascia irregularity, and subcutaneous air. Now, I think most of us think about subcutaneous air with necrotizing soft tissue infections, but you definitely don't need to have air present in order to diagnose this. This is a normal foot. So this is normal subcutaneous tissue, maybe a little bit of muscle down here, some veins, that's these circular things. This is a hyperechoic cortex here and here with some shadowing. These are the foot bones or the toes. This is pretty bad cellulitis here. If you see this, it should definitely increase your suspicion that this patient may have something else besides just regular old edema. Notice all the pockets of fluid around it. When you have increased fluid collection, it should raise your suspicion of an NSTI. This right here is another foot that has an NSTI, a necrotizing soft tissue infection. So let's pause it and we're going to cycle back to about here. Now there is a lot of subcutaneous thickening here, a lot of thickening. The architecture is all distorted, but look at this right here. This right here is hyperechoic, so it's something that's reflective with a bunch of dirty shadowing behind it. If you see this above where the bone should be, this should raise your suspicion that it is actually air. Air causes this hyperechoic little border here with some shadowing underneath it. Here's an example of increased edema and air. So we have this hypoechoic fluid around these little pockets of subcutaneous tissue. Then we have this very irregular border of hyperechoic something up here. This something is air with some dirty shadowing underneath it. This is what subcutaneous air looks like, and this is a necrotizing soft tissue infection or nec fasc. This is Fournier's gangrene, which is actually the first time that necrotizing soft tissue infections were introduced. Here's a testicle, and if you look right here, this right here almost looks like bone, but you see there's a bit of a mirror artifact down here. This is almost like an A-line. This is a bunch of air inside the tissue of the perineum. This is all a bunch of thickened tissue. This is a necrotizing soft tissue infection as well. Now, it's easy to focus in on the gas, but that's actually a later finding. The other thing to make sure to keep an eye on is the presence of a fluid layer in the deep tissues. And this is what you see here highlighted by all the arrows. This fluid thickness strike is arguably the most important thing to consider when trying to determine if the thing you're looking at is regular cellulitis or an NSTI. This study was a retrospective review of 95 patients, 48 with neck fash and 47 with non-neck fash, or regular cellulitis. And they found that the biggest differentiator was actually this fluid accumulation. This had the best predictive value for figuring out if it was cellulitis or neck fash. Now, one thing that you can also do, and this is from that same study, is look at the thickness of that fluid collection. So that's that fluid collection that's just deep to that subcutaneous tissue. And notice as that thickness increased, the specificity and the positive predictive value all increase. So the thicker that you see that fluid stripe deep to the subcutaneous tissue, the more likely it is to be an NSTI rather than just plain old cellulitis. Another thing is that if you see air present, that is very unlikely to be cellulitis. So if you see air with a very thickened stripe, be highly suspicious for a necrotizing soft tissue infection. So to recap, necrotizing soft tissue infections are very similar to cellulitis. They're just like a worse cellulitis. The two big differentiators between the two are going to be air in the subcutaneous tissue and a fluid stripe deep to that subcutaneous tissue. That's it for this week's 5-Minute Sono.
Nursing application. Nursing staff in the development of the care function and in search of solving the human needs of patients to treat necrotizing tissue infection, carry out broad spectrum antibiotic coverage by the intravenous route from the beginning, but under the preliminary guidance of the examination bacteriological, in addition to keeping the patient under full monitoring and physiological and metabolic support. Then the nurse, together with the doctor, perform sequential debridement under general anesthesia in order to detect and eliminate residual foci that can restart the process.
Necrotizing soft tissue infections, or NSTIs, are characterized clinically by fulminant tissue destruction and systemic signs of toxicity. NSTIs can include involvement of the epidermis, dermis, subcutaneous tissue, fascia, and muscle. The pathophysiology of these infections is the same and is the result of either bacterial penetration of skin and mucosal defenses after tissue injury, or with origination in the deep tissues without a clear portal or source. Bacteria gain entry into areas of relatively poor blood flow and hypoxia, which is followed by bacterial overgrowth, release of exotoxins causing local tissue damage, and widespread necrosis. Type 1 NSTIs, or polymicrobial infections, are most common and typically seen in patients with comorbid conditions. Gram-negative enteric bacteria are seen in combination with gram-positive organisms and anaerobes. Type 2 is monomicrobial, usually due to group A strep, has a more virulent course, and occurs in younger, healthier patients. Certain comorbidities and risk factors may predispose patients to this disease, including advanced age, obesity, diabetes, alcoholism, vasculopathy, IV drug use, immunosuppression, end-stage renal disease, perirectal abscess, perforated viscus, and recent surgery. Exam findings can include erythema, swelling, induration, and early tenderness. Late findings can include skin discoloration and a violaceous erythema, bulla and crepitus, pain out of proportion to examination, or anesthesia of the affected area. Most patients quickly develop signs of systemic toxicity, including high fever, nausea, vomiting, malaise, altered mental status, tachycardia with associated hypotension, and oliguric renal failure. Lab findings may include a leukocytosis with left shift, acidosis, hyponatremia, elevated lactate, and elevated inflammatory markers. Imaging is not necessary when there is a high level of suspicion and may delay early treatment. When the diagnosis is unclear in a stable patient, CT findings consistent with NSTI can include gas across tissue planes, fluid collections, asymmetric fascial or muscle thickening, and diffuse areas of soft tissue inflammation. The mainstay of treatment is aggressive early surgical debridement. Debridement should extend back to viable soft tissue and muscle that exhibits brisk bleeding. Return to the operating room within 24 hours or earlier for a second look should be strongly considered.
Pros and cons. Pros: uncommon infection. Cons: high rate morbidity and mortality. intense pain, affected tissues is wrecked, hot, swollen, and rapidly peeled. Patients appear serious healed with high fever, tachycardia, altered mental status, and impotention. Emergency surgical management which consists of a wide and complete resection and debridement of all affected tissues. Issue applied in Ecuador. Necrotizing soft tissue infection is commonly diagnosed in Ecuador. Most patients with soft tissue infection are referred from another health center at the primary level, which require early surgical intervention and antibiotic therapy for proper management. In the treatment of necrotizing soft tissue infection, in addition to requiring extensive and aggressive surgical debridement to limit its progression, it requires mandatory respiration and subsequent debridement, which may be necessary every 24 hours until all necrotic disease is eradicated.
So just before I start, I'd like to thank my co-investigators, Kristen Linder and David Nicolau, for their help in this project. So we looked at 357 patients that came to the emergency department with skin infections at our hospital, Hartford Hospital. And we excluded patients that had necrotizing fasciitis or osteomyelitis because obviously those patients had different therapies, modalities going into it. And we wanted to look at a number of different things, one of which was how many patients get treated in the emergency department and are sent home, and what happens to them after they get sent home, and what happens to the patients that get admitted to the hospital, in the outcomes for them in both going home as well as being readmitted back to the hospital. So what we found in those patients is that about 70% actually are treated in the emergency department and go home, with the other 30% being admitted to the hospital. And then if you look at the patients that come back to the hospital, it's about 25% in both groups. So about 22% of the patients get admitted, go home on some sort of therapy, and then bounce back to the hospital. And about 28% who got treated in the emergency department went home, came back to the hospital later. And then if you look at those groups of patients, it's about 60% come back with skin and soft tissue infections, and the other 40% are coming back for other reasons, all within 30 days. And so what that tells us is that there's a lot of patients coming to the hospital with skin, but most aren't actually getting admitted. So when we develop resources for treating skin infections, we need to really direct resources at the emergency departments and not just at the inpatient setting. And then we need follow-up for our patients that are going home, because with 25% or so of patients coming back to the hospital, they, in about half of those being readmitted, we're missing something on the outpatient side. We don't know what those things are yet. They might not be getting long enough therapies. They might not be taking their therapies. They might have access to therapy issues. And certainly with non-skin soft tissue related readmissions, there are other things going on with their comorbidities that might be leading them back. In fact, one of the things that we saw of the patients who got admitted to the hospital, 30% got discharged to a skilled nursing facility. So these are sick patients with chronic diseases that really need more resources, not just in the hospital, but outside the hospital.
Conclusion. The early diagnostic of necrotizing soft tissue infection is often difficult and of great importance for the prognosis. Many times it is confused with a mild infection such as cellulitis. Clinical findings in the initial phase are often carried polymorphic and will depend on the severity of the infection, the virulence of the germs, and the host resistance capacity. For this reason, it is one of the most important and most frequent causes in patients hospitalized in the internal medicine surveys, taking into account in addition that if we can carry out adequate and timely management, many complications such as sepsis, disease, necrosis, amputation, and the need for graft placement and everything can be prevented.